is a very important workshop because it means that you're going to be interactive. So entering this room means that you're all going to say something at least. So this is for those who forgot their geography. This is Scandinavian, this is Denmark, and this is where I work. Aalborg, we are part of Aarhus University, which is our third largest city in Denmark. And I work in a unit for treatment-resistant patients. It means I see a lot of chronic patients. I both see them as outpatient but also as inpatient. Furthermore, I do some consulting in our high security unit in Nykøbing Sjælland, which is for our forensic patient. Well, agitation is agitation is like fever. There's different reasons why patients become agitated, and it's just like a cluster of symptoms, and I think you all know these symptoms, but it's also very important to remember that there are many ways why, or many reasons why patients become agitated, and in most cases it's, well, almost every time it's the best thing if we treat the causing factors instead of just treating the agitation. So if it's a benzodiazepine withdrawal reaction that causes the agitation, then we should treat that instead of just treating the agitation. Well, from the start of the introduction of antipsychotic drugs, this description of an effect on agitation was described, and Henri Laborie, which was a Frenchman who discovered chlorpromazine or started to use, he was actually a French surgeon, and he recommended his colleagues to use chlorpromazine, and he described a euphoric quietude. Well, today we won't say that these drugs are euphoric, but this effect on agitation is a class effect. All the antipsychotic drugs has an effect on agitation, but some of them have perhaps a better effect than others, and I hope we can discuss that further later on. This is just a definition of agitation. We already covered that. And what about the diagnosis associated with agitation? Well, schizophrenia in the general population, most people would say that schizophrenia is what they are using the beds in our close or in our acute wards. But we did a small survey, and it was quite interesting that it was not patients with schizophrenia that were in the closed wards. It was actually patients with personality disorders, borderline emotional. These disorders were much more common than actually patients with schizophrenia. Well, agitation can be seen in all diagnoses, and many more of them than listed there. So what's the challenges with acute patients? Well, in many cases we don't know the diagnosis when they enter into the acute ward. There might be no history, and there might be conflicting somatic disease that we are not aware of, like delirium, epilepsy, or cardiovascular disease. And there might be substance misuse, and then it's always this interesting question, what's the substance? Could this be alcohol withdrawal symptoms, or could it be benzodiazepine that causes this agitated patient? So there's a lot of factors we should consider when we face these acute patients. So what's the requirements of antipsychotic treatment if we decide to use an antipsychotic drug? Well, first of all, we need a drug with an early onset of action. We need it to alleviate psychotic symptoms without adversely affecting the functional status. And this is a very important one, that we need the patient don't experience very severe side effects, because we know from data that just one episode of acute dystonic reaction will cause a very poor compliance for many years. So this if this is the initial experience for the patient with psychotropics, then it should be a very good experience. That's something we should have in mind, that just not give them the haloperidol because it might give them acute dysonic reaction, and that experience is so frightening for them, so it will cause poor compliance for many years. Then there's this discussion about the acute therapy and the long-term therapy, and this is also very interesting. We can discuss that later. And I think we'll skip. Well, in Denmark there's a lot of discussion about algorithms, and there's a lot of focus on algorithms, and every little small hospital has their own algorithm because they don't want to be the same as the larger hospitals. So there's a lot of discussion about which algorithm is best and which algorithm is most suitable for treatment of agitation or treatment with antipsychotic drugs. Do you have the same discussion about algorithms? Are algorithms popular in Turkey? Are you limited in which way you prescribe drugs? No. So every doctor is free to prescribe any drug they want, even if it's in the hospital. There's no guidelines to how to treat patients.
Hayır. No, we are not allowed to use all the drugs.
Okay, so there's a first line drug is atypicals. Yeah, okay. But no restriction about the atypicals. No.
Restriction.
Okay. In Denmark, there's in some hospitals a restriction that olanzapine is not allowed anymore as a first line drug due to the metabolic side effects. So you need to try some of the less the drugs with a less metabolic, with a better profile than olanzapine. So they are allowed to use it, but first, if the patient don't respond to like quetiapine, ziprasidone, aripiprazole, then they are allowed to use olanzapine. But you don't. But I think it's a good thing that you're allowed to choose whatever you want, because then you can tailor the medication to the patient. We are much more restricted. Due to this discussion about olanzapine, there's been a lot of discussion about switching, or if you look at our closed wards, a lot of patients are put on olanzapine, and when they're getting out, when they're discharged from the ward and then enter the community, they are often switched to drugs with a better long-term profile. Unfortunately, some of these patients stay on olanzapine for a very long time before they're being switched. They are gaining a lot of weight before they are actually being switched. So this is what usually happens in Denmark, is that we use quetiapine, olanzapine, and they achieve a remission, and first then in the long-term treatment we switch them to non-sedating drugs with a better profile. But since we had the introduction of aripiprazole IM and ziprasidone IM, it is possible to give the same drug during the acute phase as an IM drug, and then still use it as a long-term drug. Of course, we have patients that not respond to this non-sedating drug. And could you turn the mic a bit down? I think I'm very loud. Maybe it's better. I think it's better now. Well, we have patients that don't respond to the high-risk drug, then to the low-risk drug, and then of course we'll switch to the high-risk drug. But I think that's something that's important, that we tailor the medication. So when can intramuscular antipsychotics be used? It can be used in the initial acute phase. It can be used as a compulsory treatment, and it can be used when we just treat the agitation, when we don't consider or don't treat the whole disease, we just treat the agitation. That can be in patient with personality disorder, or patient on concurrent antipsychotic treatment and just having a breakthrough psychosis, or having an episode of agitation. In Denmark, we are not allowed to use depot medication as compulsory treatment. So this means that we are using these rapid-acting medication every day in our compulsory patients. Are you allowed to use depots as compulsory treatment? Yes. Even when they are outpatients? Can they still receive compulsory treatment when they are outpatients?
There is no, compulsory treatment like you.
All the patients take their medications, or?
No, the families bring them, make them get their medication and so on. So it is not like government help compulsory treatment.
Okay. What about when they are inpatient? Then they are.
Yeah, it is allowed to use.
Okay, but when they discharge, then you're not then family do make sure that the patient take the medications, or.
Yeah, when they're outpatients, you just ask the family to have them get the drug, but or they can be brought by police and so on.
Okay.
But it is not like
not
a
like
system
a
that makes compulsory treatment.
Okay. In Denmark, we are not allowed. So this means we have a lot of revolving door patients that when they are discharged, they stop the medication. When the effects is gone, then they are being brought back. So this is something, we have a very strict law about patients' rights. So that's not about psychiatrists' rights, but it's about patients' rights. So this is actually a problem. So what do we want from an IM drug for agitation? Well, first of all, we need a very uncomplicated administration. This is sometimes a problem in some of our wards with ziprasidone IM. You have ziprasidone IM licensed here. It's licensed here, yeah. And if it comes from the refrigerator, it can be very difficult to dissolve. So this is something some of the nurses are complaining of. So a drug used for agitation should be very easy to use. It shouldn't have a very complicated administration. A small injection volume is also very important. This was a problem with clozapine IM we had for about five years ago. It comes in a 25 milligram per ml. So this means that patient receiving perhaps 300 milligram should receive 12 milliliters. That's a very large amount. And the good thing about this procedure was that patients started to take their oral medication very quickly because it was very painful for these patients to receive 12 milliliters every day. Then there's the issue about absorption. Drugs used in the acute phase should have a very rapid and reliable absorption. This is a problem with diazepam used for IM because it's not very rapid and it's not very reliable. Actually, the oral medication tablets, diazepam, is absorbed as quickly as IM. So IM diazepam should not be used. Instead, we use lorazepam, which benzodiazepine is mostly used in IM. Is that lorazepam as well? Diazepam. Okay, there's only diazepam. Okay, so you have to use it. You can't get it on a patient-based, or there's no way of going and still get the medication. Okay. Then there's a long and lasting anti-agitation effect. This is why Lundbeck many years ago invented clopixyl acute-phase. I'm not sure if that's licensed. You know acute-phase? Yeah, that's a Danish invention. So it's still used in Denmark, but not that much. We use it for our chronic patient, and when everything else fails, we still rely on acute-phase. Is it popular here, or? It's popular, yeah, especially around the nurses. The nurses like this drug because one shot and then the patient are quiet for at least 3 days or something like that. So then there's the safety profile. There's been a lot of discussion about the QTc and ziprasidone. And furthermore, drugs used in the acute phase should not have any contraindication because we don't know what drugs these patients took before, or if they have any somatic diseases, etc. And then there should be no interaction. Irritation and injection site, that was a problem with clonazepam IM. It's not licensed in Denmark anymore because it was very painful for the patient. Then there's the tolerability issue. Initial tolerability, this is that we don't accept dystonic reaction in first episode patients. And then there's the long-term tolerability, and that's especially the metabolic problems. With the old drugs, we relied on 2 side effects for treating agitation. And that was sedation due to the blocking of the histamine receptors and blocking the dopamine receptors excessively, so the patient got some EPS. And the good thing about EPS is that if the patient tries to hit you, then you can always at least run or something else to avoid being hit. But with the introduction of the atypicals, especially ziprasidone and aripiprazole, we have ziprasidone for about, I think, 3-4 years, IM, and aripiprazole for 1.5 or something like that. And with these 2 drugs, I think it's to some degree possible to control agitation without necessarily sedating the patients and without causing extrapyramidal side effects. But when these drugs were introduced, we had a lot of discussion with our nurses because they think the way we control agitation is bringing the patient to sleep, but that's not necessarily right. You can, to some degree, control agitation without necessarily bringing them to sleep. So what happens at the receptor level? Well, with psychotic agitation, that's due to burst firing of dopamine. That means that the only compounds that work directly on agitation in psychotic agitation is drugs that block the D2 receptors. Then there's the histamine receptors. Agitated patients don't have an increased firing of histamine. So this means the effect from sedation is only, in psychotic agitation, is only something that contributes to the effect. This is only an indirect effect, and this is very important. So the drugs like haloperidol doesn't have any histamine blocking, but it still have an effect on a very dramatic effect on histamine, on agitation, but that's due to the blocking of the dopamine receptors. Norepinephrine is also involved, but as is, well, most antipsychotic drugs block the norepinephrine receptors, so that's not a problem. Then there's the GABA receptors. Well, a lot of these psychotic patients also have anxiety, and we might cause akathisia with high doses of antipsychotic drugs. So combining with benzodiazepine is usually a good thing in the acute phase. This is our current intramuscular options, and maybe you have some of them, and maybe you have some we don't have. So haloperidol is not very often used in Denmark anymore. We use it when everything else failed, and we switch them to haloperidol and go to very high doses. Olanzapine was very popular for many years ago as an IM drug because it was sedating and it was very easy to use. And in Denmark, I think many Danish doctors is very lazy, so they use what's most convenient, not for the patient but for themselves. You can see that on the clozapine prescription, that if patients need to have blood tests, etc., that the doctors don't prescribe it. So olanzapine was very commonly used, but The problem, it went down when this warning about sudden death in combination with benzodiazepine, and you're not allowed to combine them with IM benzodiazepine, then the use did fall. So it's not that popular anymore. Clopixel or suclopentixel is still popular, but it's only available as acute, so it's mostly reserved for our chronic patients. Ziprasidone, well, I think in Denmark there's olanzapine, and it's still being widely used, but it's not that popular as it was. But usually today most hospitals are divided. Either they use Ziprasidone IM or they use aripiprazole IM, and then there's something somewhere in between this olanzapine. And these two drugs are quite similar in the way they work. In our hospital, we usually use aripiprazole because we prefer the tablets. Ziprasidone tablets or oral medication is not very popular. They have if you look at the side effects, it should be very popular because metabolic side effects or metabolic syndrome is something that really aggravate our patients, and it has a very high rate in patients with schizophrenia. But ziprasidone is not very widely used. It's less than 5% in Denmark. So, and then we have the benzodiazepine, and most popular is lorazepam. We are discussing benzodiazepine a lot in Scandinavia. In Norway especially, they are very reluctant to use benzodiazepine. In UK, they are very free to use benzodiazepines. It's considered as good practice to use benzodiazepine. I'm not sure in Turkey what's your attitude to benzodiazepines. What's your attitude to benzodiazepine? You often use them. You use them alone, or I think you should?
We often use benzodiazepines in acute agitation in Turkey, but in oral forms.
Okay, both as oral medication as an IM.
Excuse me?
Both as oral medication, as tablets and IM.
We can only use oral tablets because we don't have intramuscular form except diazepam.
Yeah, but you use diazepam? Yeah,
Yes.
sometimes?
Sometimes.
Okay. What about the problem with long-term treatment?
We cannot get enough response in long-term treatment.
Okay, so they're being discontinued, but you're not afraid of them being addicted to the benzodiazepine?
Yes, short term. We use short term and
Okay.
then slowly taper the dose.
Okay. The problem in Denmark is that they're very cheap, and a lot of these patients stay on their benzodiazepines, and doctors are not so good at trying to discontinue this benzodiazepine. So it's a very potent drug, so it should be used in the acute phase, but the problem is the long-term phase. Yeah.
Bizde benzodiazepinler kontrollü reçeteye tabi.
Okay.
Okay. Bizde benzodiazepinler resmi reçeteye tabi, kontrollü. Onun için hasta doktor yazmadan alamaz ve özel bir reçete. O yüzden kötü kullanım daha az. Daha önce lorazepamın da intramüsküler formu vardı ama artık çıkmıyor Türkiye'de.
Yeah, this is a good way of controlling prescription of benzodiazepine. We have the same with the opioids in Denmark, but not with the benzodiazepine. So if you make it more difficult to prescribe the medication, then it will go down. So I think that's a good thing. So the benefits of benzodiazepine is that they are sedative. They have a direct anxiolytic effect. They are usually very uncomplicated to administer, have minimal contraindication, and we even have an antidote. So this is a very potent drug, and it should be used, and the drug should not be blamed that some doctors use it incorrectly. So this is a very potent drug. And the risk is paradoxical effect. Does anyone of you seen paradoxical effect? This is something that really splits doctors. Some doctors always see paradoxical effect, and some doctors never seen paradoxical effects. The paradoxical effect is when you give a drug, when you give a benzodiazepine to an agitated patient, and they become more agitated. Have any one of you seen paradoxical effect? Daphne?
I have, but it is difficult to differ it from delirium sometimes, because it was in a patient that had lots of patients, lots of drugs. So maybe it was paradoxical effect. Maybe it was just, delirium because of lots of medication.
Yeah, it's always the question, if you give a benzodiazepine to an agitated patient, you can always say that he's still agitated, you just give him some more, and you have to give him some more a few times and see that you have a dose-response relationship, that he really becomes more and more agitated. Otherwise it can be because you have actually under-treating the condition. So it's very difficult to establish that this is a paradoxical effect. But it's very interesting. It should be, well, it probably exists, this paradoxical effects. We see it on alcohol. Patients that drink alcohol, they more often commit suicide, they are more disinhibited. So the GABA receptors is involved in this control of agitation. So it probably exists, but at what rate is very difficult to say. Respiratory depression in overdose, well, this is very easily counteracted with the antidotes. And dependency, well, why people become depending on a medication, I think that's mostly something to do with their personality more than any other things. So to some patients we should be reluctant to use the benzodiazepine, but in other patients they will never become addicted. In our, we have some electronic prescribing module. Then you have to make an active. If you prescribe benzodiazepine, it's automatically prescribed for, I think, 2 weeks, and then you have to renew the prescribing. So this is a way of trying to make it more difficult. This is actually a Turkish model in a way of making it more difficult to maintain patients on benzodiazepines. And then, of course, there's the withdrawal symptoms. Rating scales, is the use of rating scale in Turkey, is that popular? Do you rate the patient routinely? We don't do that, but we want to do that. But it's not introduced in all wards. But in some of our more special units, we use rating scales. If you look at the rating scales for acute agitation, then the PANS excited component scale is the most popular and most widely used in the clinical trials. It consists of 5 items from the PANS scale. I think you all know the PANS scale, but you might not be familiar with the PEC scale. But the PEC scale is derived from the PANS, and it consists of these 5 items, and the score for each item is like in the PANS, it's 1 to 7, with 7 extreme and 1 to absent, and then you get a total score between 5 and 35. And a severely agitated patient is around 30 and above. This is the items of the PANS scale. Do you know the PEC scale or have you used it? No. It can be put in a paper like this. And in some of our wards, we use these routinely when the patients are being admitted, or if they are being restrained, then they do this every hourly or something like that until they have control of the agitation. It's a good way of documenting the effect of the treatment. Another rating scale is the ACES rating scale. It was developed by Eli Lilly. It's a 9-point scale, and if you have a 1, then you are marked agitated, and if you have a 9, you are unarousable. So this covers both agitation and calmness. It's very easy to use and very quick to use in the wards, and can be used by the nurses. If you look at the adverse effects in the acute phase, the acute dystonic reaction is not very common anymore, but we still see it in especially our younger male patients. Do anyone know why younger male patients are more prone to get acute dystonic reaction? Well, there are several reasons. Younger male patients are usually more violent, and they usually receive higher doses. Furthermore, they have more lean body mass, they have less fat. So this means if you give it an injection, then the distribution volume of a single injection is smaller in younger male patients compared to older female patients. So more will go to the active side, more of the drug will go directly to the CNS, because these drugs are lipid soluble. So that's one of the reasons. The age is mainly due to that these patients they have more vulnerable receptors. They are more sensitive at the receptor sites compared to chronic patients. Well, acute dystonic reaction can affect any muscles, but we don't know why. But the cheek and the tongue is very often affected. But why these muscles are more affected than other muscles is, I don't think anyone knows that. If they do, then please tell me now. Well, treating these patients, it can be done with IV or IM anticholinergics. If you do IV, then you very often, before you empty the syringe, they rise their head, so it's very effective. Have all of you seen acute dystonic reaction? You've seen, yeah. And have anyone talked to a patient afterwards about acute dystonic reaction? Patients remember the side effects, because first time they experience these side effects, they haven't been warned about these side effects. It's just something that comes up, and like they are being more stiff, and it's hurting them, and they're being frightened. So this is a very bad experience for these patients. Yes, akathisia is, well, the definition is, and restlessness is very interesting side effects, and it can be very difficult to diagnose, because it's very difficult to distinguish agitation from akathisia. I'm not sure I always can do that, but I don't think there's that many good advices what's akathisia and what's agitation. Do anyone of you have any? How do you distinguish these two things? How do you distinguish between agitation and akathisia? How do you distinguish? Yeah.
We can distinguish them. Akathisia is mostly in legs.
Yes.
That's why they are always turning around.
Yeah.
They can sit down,
Yeah.
get up all the time and going in the room. So I can see that agitation is more like the.
It can both be the
Yes.
legs but also.
I can differ
verbal.
them from the movements.
Yeah.
I can see the movements and say akathisia mostly, or agitation is getting struggle with the hunger. That's
Yeah.
why it's more difficult, different.
Yeah, I think that's a good way of. Usually, if it's true akathisia, most patients would say that they just need to walk. But in some cases, it can be more psychic than actually a physical. So it can be very difficult to distinguish. And I think another factor is the time. If you gave patients haloperidol and they afterwards become very agitated, walking back and forth, then it must be akathisia, and it's more likely to be akathisia than true agitation. So the time factor is also important in distinguishing. Well, most of all, it's very important. If you can distinguish, then you should treat them with a benzodiazepine, because that works in both. But because if you give them haloperidol or continue to give them antipsychotic medication, you will mostly worsen their state, because you are worsening their akathisia. So, I think we covered most of them. Impact of over-sedating. Well, sedation is also something very interesting, because some patients really like to be sedated, and some patients don't like it, and they don't accept it, and they quit the medication. So this is a good way of showing that medication should be tailored. It should be tailored to the right drug to the right patient, and none of the drugs works in all the patients. In the acute phase, a lot of diagnosing is done in the acute phase. So it can be quite difficult to diagnose a patient if it's, first of all, he's being over-sedating and having a lot of EPS. So this is could be a reason for not using some of the non-sedating drugs, because it might be more easy to actually diagnose the patients. Cardiac safety, well, that's mostly an issue with ziprasidone, but there haven't been any TDP, there haven't been any torsades arrhythmia with the ziprasidone, so it's mainly an artificial problem. It's mainly a problem on the ECG more than a problem in real life. The clinical trials, well, the clinical trials in acute psychiatry is not that important, because there are several problems when conducting trials in this population. This is a smaller trial that was investigating whether we should use lorazepam or use benzodiazepine alone, or we should combine it with an antipsychotic drug for agitated patients. And in this small study, there were no difference between lorazepam alone or combined with risperidone or haloperidol. But the study might be too small, but it's very difficult, because the patient have to give informed consent, so it's very difficult to conduct these trials. This is a study comparing IM olanzapine with IM haloperidol. This is not that interesting, but it's just showing that this is haloperidol, and the other doses of olanzapine, except for the 2.5, have a similar response to olanzapine. The most important thing in this study is actually this slide. If you look at the PEC scale, the mean baseline, the PEC score was around 18, 19. That's not agitated patient. That's patients that are willing to some degree agitated, but they are willing to give informed consent. Most of our patients we see in our clinical, in the wards, in the acute wards, they have a PEC score on 30 or something like that. So the way we tested this drug, or the way this drug was licensed, is in two different populations. This is not true agitation, this is semi-agitation. So this is the problem in all the acute trials, that the patients are not that agitated compared to the one we see in daily clinical life. this one is about the use of IM ciprasidone and restrainment. And as you can see, after the introduction of ciprasidone, it was reduced. So this is not that true. Then the worst case scenario. Well, what do we do when patients fail on our usually algorithm? How do we treat the patient if they don't respond to the maximum dose of olanzapine or ciprasidone? Do we do like this, just top up with another drug, or do we just maintain them on benzodiazepines and give them more benzo, or what's the strategy if patients fail? Do you have any comments on that? Yeah.
We, in our use, we firstly stitch with the,
Restrain?
and with the rope, not rope, the restrict.
Restrain.
Yes, restrict. And then, if agitation is not finished with the drugs, we use ACT,
Yeah.
acute.
Involuntarily.
Yes, electroconvulsive therapy. It's very useful.
Yeah. So that's
Yes.
that's the worst case scenario. You use it every day, bilateral. Okay.
And then maybe the other day, 7 program.
So you give
program.
one treatment and then wait for.
Go on, yes, go on tomorrow, and then 1, 2, 3, and then
Yeah.
one day not taken.
Yeah, I think we call it East-Yang block. Yeah. Yes, we do that too. Other strategies in the patient that fail? Do you go above the licensed dose of the antipsychotic drug? In Denmark, olanzapine is maximum licensed at 20 milligram. Use more than 20 milligram olanzapine.
milligram.
How much?
30.
30? Okay. So that's common, all go to 30. Yeah.
Rutin çalışmada.
Okay. Yeah. So, what's the role of benzodiazepines in these severe cases? Are you reluctant to use them if they receive a high dose of antipsychotic drugs, or do you just continue?
Ativan'ın şeyi neydi? Ativan.
Yeah. Yeah. Use Ativan.
Suplinget, dilaltı emilen tabletlerini de acil uygulamada ajite hastalarda veriyoruz.
Okay.
2,5 miligram ya da 1,25 miligram acil uygulamada veriyoruz. Yine bazen şey yaparız, klopüksol akifaz o uygularız. Genelde iyi sonuçlar alıyoruz. Ben askeri hekimim. Bizde askerler genç hasta ve genelde madde kötü kullanımı veya antisosyal kişilik bozukluğu olanlar geldiği için tabii gençlerin tespit edilmesi daha zor. Bu tür uygulamalarla onları daha iyi kontrol altına alabiliyoruz. Olanzapini bir ara kullandık ama şu anda pek kullanmıyoruz. Ciprasidon zaman zaman ama daha çok klopüksol akifaz. Daha çok tercih ettiğimiz. Diazem intramusküler nadiren kullanıyoruz. Sizin de söylediğiniz gibi emilim zorlukları o hep yıllardır bilinen bir durum. Sanırsam o bizi uzak tutuyor uygulamadan. Evet.
Yeah. Well, your strategy is quite similar to the way we do. We also rely on AccuPhase in these very severe cases, and ECT. In some patients, it is very rarely used, but in some, especially in manic patients, we can use a short term of clozapine. But this is only when I'm on call, and a few doctors more, they would to use it. But clozapine, if the patient can corroborate with blood monitoring and take all medication in these manic patients, clozapine can be very effective, and it works very quickly. And the way we do it is we usually start by 12.5 milligram and monitor the patient to see, especially the orthostatic hypotension, if he's running around in the ward, don't take the blood pressure, that's not necessarily. But then just after an hour, then give 25 milligram, and if that's well tolerated, you can increase, and then every hour or two, every second hour, give 25 to 50 milligram of clozapine, and the patient will get to sleep. And this is not necessarily going to be a long-term treatment. It can be tapered off after a few months or something, or a few weeks. So it can be also used as an acute drug. It's usually very effective. And we also use bilateral ECT. Yes. We also have restraint. This is the way we restrain. We usually restrain them only with the belt around the waist. And only in the most severe patient we will restrain the arms and legs as well. Yeah.
I don't see agitated patients for a few years, but in the place where I was educated, we also used haloperidol IV sometimes. And it was, for example, it never caused, I haven't seen it cause dystonia at all. So, and it was very effective. If you can find the vein, do you have an experience with that? What do you think about haloperidol IV?
Well, it's used in somatic hospitals for delirium patients because they usually have an IV access. Then when we psychiatrists go there, it's very easy to say, give him IV, but in our wards it's not used. In some hospitals in Denmark, diazepam IV is used, but that's when anything else has failed, even ECT and everything else. So then they sedate the patient with diazepam IV. The problem with diazepam IV, and the reason why it's not very often used, is that many of the Danish psychiatric hospitals is placed very maybe apart from the somatic hospitals. So if you give too much haloperidol, then it could be a good thing that you can just roll the bed into the intensive care, but that might be 10, 15 kilometers away. So that's why we're not that eager to use IV diazepam. IV haloperidol has been reported to cause torsades de pointes arrhythmia more frequently than any other drugs, any other antipsychotic drugs actually. So, but maybe the reason why is that it's used for somatic bad patients. So patient having somatic problems, we tend to use haloperidol. So that might be the reason why we get a lot of cases on torsades de pointes arrhythmias. Restrainment is becoming much more complicated in Denmark. If the patient is being restrained, the doctor have to see the patient 4 times per day, and it should be divided during the whole day. So if you do it, you have to see them even in the night. And even then, even though they are sleeping, you have to go in and see. You don't have to talk to them. You have to go inside and write on the protocol that you've been there. And that's a way of trying to decrease the use of restraint. Restraint is not very often used it's not allowed in many countries. In the UK, they don't use restraint, they use seclusion room. And if you've been to UK, I think I would prefer restrainment actually, because the seclusion room, they are not very comfortable. Do you have seclusion rooms as well? No? Okay, and you're allowed to use them in some hospital? Yeah. Okay. Only in one hospital in our high security, it's our national high security forensic hospital, they are allowed to use seclusion room, but other hospitals are not allowed. So I think to some patients seclusion room might be more suitable and other patients would benefit more from restraint. So it would be a good thing to have both possibilities. Well, then I brought a few case stories we could discuss, and these case stories is not it's not necessarily a good way of treating patients, so it's just the way it was done. So feel free to comment and ask questions. Well, are clinical experience important? Yes, they are very important, and the reason why is, as we discussed, that patients from the clinical trials differ from the patient we see in the wards, because these mainly due to the fact that these severe agitated patients, they cannot give informed consent. And it's also very difficult to compare drug treatment, because even though with the atypicals and even though we think that the PEC scale is universal, a lot of other scales is being used, and it's very difficult to compare the effects of the atypicals. And in the real world, there are no inclusion or exclusion criteria. We have to treat all the patients, even the patient with substance misuse and patient with cardiovascular problems, etc. So case stories is important. Well, case number one is a 48-year-old female with a chronic schizophrenia having command hallucination, and she was treated with Depakote or valproate 1500 milligram and clozapine up to 700 milligram, and she prior had a response to Clopixel. What would you do in this case? You would choose Clopixel, yes. Always consider prior response. I think that's the main reason. If you, to younger colleagues, always say to them, look for prior response. If the patient responded to Clopixel Accuphase, then give him Accuphase. That's the best predictor of a new good response. Another reason or possibility is to increase the clozapine dose, but consider if you consider the sedative and hypertensive properties of clozapine that don't increase more than 50 milligram. So use rapid strength with Clopixel Accuphase. We tend to use IM, 100 milligram. That's like the standard dosage. In some female patients we give 75 or 50, but that's very rare. Usually all the patients receive 100. Is that the same here? Yeah, so use 50.
We have 50 milligram intramuscular form. We can use.
Telephone.
We have depot form. It's
Depot of Clopixel.
Yes, we have depot form, but it's 200 milligram, I guess.
Yeah.
Acufaz is 50 milligram, and
How
depot
much?
form is 200 milligrams.
Yeah, and the Accuphase is.
Excuse me?
Which dose of Accuphase do you use?
50 or 100.
50 or 100, yeah. That's quite the same. Yeah. Any comments on this case? No, let's move on. Case number 2 is also a clozapine patient. I see a lot of clozapine patients, so that's why most of the patients are treated with clozapine. Well, this is a very agitated patient, have a PEC score about 30. It's almost as double as the patient from the clinical trials. He was paranoid, and he did not have any response to haloperidol, giving 10 milligrams 3 times. He was treated with Clopixel Accuphase for 3 days and received 3 injections, so it means he was kind of agitated for more than 9 days. And in this case, we consider ECT, and he received ECT and had a very good response after 2 or 3 treatments, actually. So ECT should not be forgotten. This is when everything else failed, we should always consider doing the ECT. Case number 3 was a 50-year-old man with a paranoid schizophrenia, having visual hallucination and sweating. What would you consider in this case? This could be a case of delirium, and in this case use benzodiazepine, antiepileptics, or the phenobarbital. The last one is mainly used in the Scandinavian countries. I don't know why we use it. I don't think there's any good reason why we use phenobarbital for treating delirium, but it's an old tradition. What do you use for delirium in benzodiazepine, diazepam? Yeah. And, sorry? Antipsychotics as well. For delirium, for alcohol withdrawal symptoms?
For delirium,
With psychotic delirium.
we prefer diazepam for alcoholic delirium because of alcohol, but the other type of delirium,
Yeah.
we use antipsychotic.
Yeah, that's something. Delirium in some countries, it also includes psychotic states, but in other countries it only includes the delirium caused by alcohol withdrawal symptoms. Yeah. One of the main problem with alcohol withdrawal symptoms is that especially young doctors suddenly are one of the main problem with the alcohol withdrawal symptoms is that some doctors get frightened if the patient needs very high doses of benzodiazepine or phenobarbitals, and then they tend to give them antipsychotic drugs. But in those cases, we should stick with the benzodiazepines because we are trying to treat the causal factor of the agitation or delirium, and that's alcohol withdrawal symptoms. So we should stick with the benzodiazepine. Only in very rare cases you could use a very low dose of antipsychotic drugs in patients not usually receiving antipsychotic drugs. Then it will have dramatic response because then you sedate them with the histamine receptors, and that's why if they are very tolerant to the GABA receptor because they drink a lot of alcohol and they have a personality disorder, in those cases we sometimes use a small dose of antipsychotic drugs as well. But first, after we loaded them with benzodiazepines. Any comments or questions in how to treat delirium? No? Case number 4. This is a 24-year-old male patient admitted due to aggressive behavior and hallucination. He was on olanzapine, and I think he was admitted due to partial compliance, and the dose was increased to 30 milligrams. And during the next day, he experienced a worsening. He became more agitated, but he became more or less hallucinated. What would you consider in these? What? Akathisia, yes, of course. And he started to refuse all medication, and we gave him olanzapine IM, and we actually saw a further worsening. So this was treated with clonazepam PRN with good success, and we did control the agitation, but in the first case we actually worsened the agitation. And case number 5. This is an 80-year-old man, first episode man. He was admitted involuntarily, and he was drug naive, paranoid, hearing voices, 14th session. It was very easy to give him the schizophrenia diagnosis because it was very obvious. And he was treated with Abilify IM. He had a very good response, and he did get 1 injection every day, and then he was switched or transitioned to oral treatment, and then we increased the dose to 50 milligram. This is a very easy case, but I brought this case to show that it's very important to give patient a good first-time experience with antipsychotic drugs. It's a good thing that we show the patient we can control your agitation without giving you a lot of side effects, and you can continue with the same medication for long-term treatment. I think this is the 5 cases I brought. Consideration when choosing rapid tranq. Well, always consider the current antipsychotic drug. If the patient is on a sedating drug, perhaps it's possible to increase the dose or give something from especially in the clozapine patient, take some of the night dose, take something maybe 100 milligram from the night dose and give them during the day. That might control agitation. And then what we already discussed was the prior response to rapid tranq. In some wards, it's actually the consultant usually write on the case note that the preferred rapid tranq. So the junior doctors, they can see what they should prescribe in case of rapid tranq. I think that's a good way of helping younger colleagues to know what they should do in these emergency settings. First episode schizophrenia, we always consider that they are very vulnerable to antipsychotic drugs, so we should treat them very gentle, otherwise they will get extrapyramidal side effects, and we will make it more difficult for other doctors or other care persons to maintain them in antipsychotic treatment. Physical illness, this is especially about the tolerability issue. If the patient gain a lot of weight, then try to remember that either if you use the high-risk drug, the high-risk metabolic risk drug, switch them if possible, or the other possibility is to start on a low-risk metabolic drug and maintain them on that, and only switch them if they don't have a proper response. And then always be sure if the patient is agitated or having akathisia. I think we covered this question. This one, in Denmark there's a lot of discussion about whether combining benzodiazepine and antipsychotic drugs is harmful, and whether this increases the risk of sudden death. There was this, the National Health Board made a survey from the registers, and they found that there was an increased risk of sudden death during treatment with both antipsychotic drugs and benzodiazepines. But the reason for this might be that the patient receiving benzodiazepine is more ill, and that might be a confounding factor more than is actually true. But if you use too sedative drug, then of course you have a higher risk for respiratory depression. And then do we sedate our patient unnecessarily? I think we also covered that. Which patient profile for each drug? Well, I think it's a bit difficult, but it should be the other factors that should give us the opportunity to decide the right drug for the right patient. I just covered or included a few slides about additional reading. This is from the NIH, which is the National Health Service in UK. This is the NICE guidelines. They have it can be downloaded from the internet. It's very useful for especially younger doctors. And this is the SLAM, South London Maudsley guideline. This is something we didn't cover much today. This is the de-escalation or non-drug measures. And this is something that is actually very important. We know from some of these placebo-controlled trials in acute phase that the placebo arm actually do very well. Maybe 60% of the response is also achieved in the placebo arm. And that's the reason why that is when patients are admitted to the acute wards, they are in a locked ward and they are being, it's all what the nurses actually do is something that's very effective on the patient, actually more effective than the drug we use. So it should be considered. The SLAM guideline recommends lorazepam or promethazine, that's antihistamine. In the Scandinavian countries, we don't have a tradition for using antihistamine, but it can, of course, be used. Instead, we use these low-potency antipsychotic drugs like levomepromazine or chlorpromazine as well. Of the atypicals, they recommend olanzapine or risperidone as oral treatment. And if that doesn't work after an hour, then you can continue and you can combine sedatives and antipsychotic drugs. And if the patient don't want to take IM drugs or the patient haven't responded to that, then you can go to IM drugs, and they recommend haloperidol, olanzapine, lorazepam, or midazolam. And if the patient is tolerant to benzodiazepine, you can use IM promethazine. We don't have promethazine in Denmark. I'm not sure. Do you have it? No. And then you can do as in this box, but also combine with for instance, haloperidol and lorazepam. That's a very widely used combination. It's also cost of 5+2, and I don't even say the names of the drugs. They just say 5+2, and that's how most agitated patients in UK are being treated with the combination. If that fail after 30 minutes, then you can use IV drug like diazepam, 10 milligrams given over 5 minutes, and repeat if that doesn't work. And then if that doesn't fail, if it fails, then you can seek expert advice if you can find an expert. So, and that's like being sedating the patient. So that's, yes, this is my final slide. Any questions or comments?